Okay, good morning, good afternoon, or good evening, everybody, depending on where you're joining us from. One more time, this is Sophia DeLaviore with the Reproductive Health Supplies Coalition, and we're really excited to be hosting this webinar through the new and underutilized Reproductive Health Technologies Caucus. Just a quick moment of housekeeping. All attendees are in listen-only mode, so you're automatically muted to prevent background noise. Over the course of the webinar, as questions arise, I encourage you to please submit those through the questions feature on this webinar platform, and we'll hold the Q&A at the end of the webinar, and we'll try to get to as many questions as possible. If you're having any technical challenges, please feel free to write into the chat, and we'll do our best to address those. With that, I will turn it over to Heather to get us started.
Thank you, Sophia, and good morning, everyone. Over the next 60 minutes or so, we'd like to give you an overview of a project that our team conducted primarily in 2017 that was funded by the Bill and Melinda Gates Foundation with the aim of re-envisioning the future of women's contraception. So over the course of this presentation, you'll be hearing from the 5 speakers you see here, and I'll let each person give themselves a little introduction as they move into their section. But I'm Heather Vedat, and I'm the Associate Director of the Contraceptive Technology and Innovation Department at FHI 360. So, as many of you may know from either personal or professional experience, numerous methods of contraception exist. You may also know that few, if any, methods are highly endorsed by those who use them. In fact, most products are tolerated at best. This is likely because few products were initially developed with input from users. So for this project, we aim to flip the development process by asking, can we start with the end user in mind? To do this, we leveraged a human-centered design, or HCD approach, that engages a multidisciplinary group of stakeholders comprised of designers, potential users, product developers, and researchers to ideate and generate out-of-the-box solutions around a central problem. In this case, of course, developing more user-friendly contraception. So as a bit of background for the why for this project, nearly 1 in 10 women globally have an unmet need for contraception, meaning that they are of reproductive age and are not using a modern contraceptive method, despite having the desire to delay or limit future childbearing. The level of unmet need varies with, for example, about 14% of women in South Asia and 24% of women in Africa falling into this category. There are many barriers to contraceptive use, ranging from lack of access to methods, lack of access to trained professionals for removal services if applicable, and of course the side effects such as bleeding disturbances, weight gain, and other issues. So why did we adopt an HCD approach? Well, we were able to observe that HCD has proven to be a successful approach in other product areas as a means of fostering disruptive thinking, which was very appealing to us. And the HCD approach explicitly calls for identifying user needs for gaining insights into what is driving them with respect to contraceptive need. It also focuses on the inclusion of a diverse set of experts that can bring a fresh eye to the challenge and extrapolate ideas based on their experiences in their respective fields. The HCD approach is also flexible and includes a vast toolbox of methods that can be utilized to generate and stimulate ideas and solutions. We were particularly interested in developing concepts for new contraceptive technologies that met the needs of women in low-resource settings, recognizing that sociocultural and health systems contexts that influence contraceptive use vary widely. We aligned on Kenya and India as the 2 locations for our work, and while both countries have relatively high levels of contraceptive use, their method mix varies quite dramatically. As you can see here, there are several methods that are divergent between the 2 countries. For example, sterilization is 39% in India versus 3% in Kenya, while injectable use is less than 1% in India compared to 28% in Kenya. Implants are not available in India, but account for over 10% of method use in Kenya. Overall, there's also just a wider range of methods that are available to Kenyan women. So with that, I am going to hand over the presentation to my colleague, Babita George, who will talk to you about how we built our HCD strategy. Babita?
Thank you, Heather. My name is Babita, and I'm a partner at Quicksand. We're a human-centered design firm based in India. Over the next few minutes, we'll take you through how we went through the HCD process in the course of this project, going from research to the workshops that we ran in both countries, and thus generating ideas for future contraception. Next slide, please. To give you a quick overview of who we met in both countries, the women as the core users were at the center of our inquiries. But in understanding the woman's needs, we tried to understand current contraceptive behaviors and practices, as well as larger attitudes and perceptions around sex, birth control, reproductive health, larger attitudes towards family planning. But in addition to the women, we also wanted to understand the larger domestic ecosystem and support structures that women have, as well as the contraceptive and healthcare ecosystem. Thus, in both countries, we worked with several NGOs to identify women aged 16 or older who had experience using contraception. We also talked with husbands and partners, as well as healthcare providers, chemists, religious leaders, as well as policymakers located in each country to understand how these social and cultural contexts impact contraceptive use. Next slide, please. This gives you an overview of the locations that we went to in both Kenya and India. Across the two countries, a goal was to explore a diverse range of perspectives, from people living in large urban settings and their peripheries like Nairobi, New Delhi, and Calcutta, as well as smaller towns. We wanted to get a range of contexts across factors such as city size, development stages, different sorts of occupations, access to healthcare, and cultural practices. Next slide, please. So the research team that conducted research in the two countries were divided into three. The teams consisted of researchers and designers from both FHI 360 as well as Quicksand, and an independent partner, Pabla Van Heck. In both countries, we also teamed up with local guides. They served as translators, but also as very crucial cultural guides. This slide gives you an overview of the various research formats that were used in our interactions with women and other stakeholders. This ranged from one-on-one discussions with women about their experiences, group discussions on contraceptive use and ideal products, context visits to various settings to understand how these women live, work, access health and family planning services, as well as intercepts and brief interactions with members of the community to get a sense of the larger cultural norms and practices. Overall, we spoke to more than 300 women, partners, and other stakeholders across the two countries. Next slide, please. This slide is a quick overview of a day in the field for one of the teams that was meeting young women. So the day consisted of in-depth interviews with girls as well as other stakeholders like their parents, school principals, teachers, people who had an influence on their perceptions and use. We also conducted intercepts in the neighborhood with pharmacists, shop vendors, and other areas that the girls might spend time in. We also ran focus groups with these girls after school. There were a range of tools that were used in the course of research, and after research, every day the teams met separately to synthesize what they had learned over the course of the day. And at the end, the three teams met to kind of begin to understand what were the larger learnings that we had from the field. Next slide, please. This slide is a quick overview of the 8 thematic areas that our insights and learnings fell into. Later in the webinar, you'll get to see how some of these insights really helped us provide the prompts for ideation during the workshops, as well as formed the basis for the design considerations that we developed. Next slide, please. In addition to analyzing the data to identify these key themes and relevant insights, we also considered how the women that we met fit along a reproductive journey from menstruation to menopause. You will see some key milestones along this journey. There are several others. We've called out a few of them. You will also notice 4 colors along this journey. These colors represent 4 phases. Starting from discovering, which is the first phase where a girl is having her first period, is encountering sex, beginning to get more familiar with relationships, her own body. The second phase is that of adjusting, where a woman is beginning to relate to others through a relationship, marriage, and often their first child. The third phase is that of balancing, where women are really balancing the requirements of their partner, children, household requirements, as well as work. And in the final phase, which is continuing after the children have grown up, the burden of the family has lessened and she's beginning to focus on some of her own needs. Next slide, please. Keeping in mind our goal to develop new contraceptive products that were really responsive to women's needs, we tried to develop user profiles based on composite information from the women that we met during research. These profiles were really developed qualitatively and do not represent an exhaustive typology, but were meant to provide rich inspiration to our ideators who needed to keep in mind that different women might need different forms of contraception. The same product cannot fit the needs of all women. Some of these profiles are unique to either Kenya or India, but most of them represent types of women found in both countries. When developing these profiles, some of the things that we considered were women's level of personal agency, the types of relationships that she had with her partners, family members, and the larger community, as well as the kind of access that she had to work, to finances, as well as to family planning services. On that note, I'm going to hand over to Neha.
Next slide, please. Hi, my name is Neha, and I'm a partner along with Babita in Quicksand. So I will talk you through the ideation workshops. We conducted these ideation workshops in both countries, Kenya and India, after the phase of research. The aim of these workshops was threefold. One, it was to come up with new and disruptive ideas in contraceptive technologies for women. Two, it was to emphasize the value of human-centered design to the field of contraception. And finally, it was to encourage cross-pollination across diverse fields. So all of the research material that got generated in the previous phases, we brought that into these ideation workshops in the form of collaterals that brought to life the user's context in these settings. This effort to keep the voice of the user present and prominent in the room allowed for all the ideas to be tempered against these women's realities. Next slide, please. In each of these countries, we conducted a 4-day ideation workshop, which was attended by approximately 50 to 60 ideators. These ideators represented a wide range of professional backgrounds and drew not only from Kenya and India, but also from the global and the international setting. The invitees included scientists and product development experts, clinicians, social science experts, reproductive health advocates, designers, amongst others. Next slide, please. So these workshops were highly participatory and were designed to lead the ideators through a series of complementary phases so that in the course of this workshop, an ideator would become increasingly familiar with the realities of women that we met, and then finally be able to design and develop and refine ideas for new contraceptive technologies as responses to women's needs. So on day one, what we did was that we broke up the participants into smaller groups with a mix of local as well as international participants in each of these groups. And we went out into the context. We went to clinics, we went to NGOs, we also went to markets, and finally we also went to a lot of places of work. And these were all around the ideation venue. The idea here was to give the ideators a first-hand experience of women's day-to-day lives. What was interesting was that when we had a feedback session later during the day, we learned that even an immersive session like this proved to be foundational and valuable even for our local participants. On the right, what you see are these zines. We created these zines as takeaways for each of the workshops. Now, they were meant to bring together stories and anecdotes from the field, communication around family planning, advertising, as well as other relevant snippets of cultural information. All of it was packaged in a light way and was meant to complement the research findings. Next slide, please. On day two, the participants were exposed to the findings of the foundational research. This took the form of a range of formats. We created videos, we also had posters, cards, as well as decks that were extremely visual. All of these collaterals highlighted the user's needs, their context, their challenges. We designed different breakout sessions where small groups would learn more about user profiles, their personal lives, their aspirations and behaviors, as well as their experiences with contraception. And the group sessions were encouraged the participants were then encouraged to identify the key challenges and then brainstorm potential approaches to address them. What you're looking at on the left is something called a challenge card, and we created these where we captured key challenges faced by users that we had met across the field research. And on the right-hand side, you see these user profiles, and these were created as a synthesis of the women we had met, something Babita mentioned earlier, and we used these in parallel with the challenge cards, where they were meant to shed light on the women that we had, their environments, their aspiration hurdles, and again, their experiences with contraception. Next slide, please. So in phase 3, which was also day 3, we invited participants to think out of the box during several exercises in which they imagined these worlds of the future. So what we did was that in order to get them to think about these moonshot and future-facing ideas, we organized a headline framing activity during which the participants wrote down these headlines that they imagined could exist in a world in the future, and then they placed them on a timeline which ranged from present to the far future. The idea with this then was that the participants were tasked with choosing a few of these headlines, and they had to use that to come up with a contraceptive idea that existed in this world, which was defined by those headlines. This is what you see on the right-hand side. This exercise resulted in a range of ideas that were not only innovative and quick and rough, but they provided a base for further refining and inspiration for the final ideation rounds. Next slide, please. Finally, the participants worked in smaller groups to generate and present CT ideas. We used two formats to help facilitate and guide this idea generation. What you're looking at on the left is a more concise format which was introduced earlier to help structure the thought process, wherein a participant was meant to write the value proposition behind an idea. The second template was a more detailed format where the idea could be detailed in terms of the mechanism, the format, which user it was meant for. Finally, once we had all of these ideas, the full group and the ideators voted on these ideas. The ideas were primarily voted on A, the ability to increase uptake amongst our users, and B, to improve the current user experience. And a subset of these ideas was finally sketched, and it was refined, which you see on the right-hand-most side. And then they were tested with some of the women and their partners and other stakeholders who were present during these workshops because they were from the nearby context or from our previous field research phase. With that, we end the workshop section, and I'd like to hand it off to my colleague Betsy.
Next slide, please. Thank you, Neha. So my name is Betsy Tolley. I'm the Director of Behavioral, Epidemiological, and Clinical Sciences Group at FHI 360. This slide summarizes the first part of our webinar. So our goal was to engage through our research phase with a broad range of women in multiple contexts to understand the reproductive and broader goals, as well as their unmet needs for contraception, and then to distill these needs into design principles that are further shared during our ideation workshops, and then through those ideation workshops and beyond to develop products that meet the needs of women and couples. Now we'd like to present, so in the remainder of this webinar, we'd like to present two different case studies that illustrate how we went from the research insights that related to our user profiles in order to identify specific contraceptive considerations. And finally, to generate these concepts that Neha kind of gave you a glimpse of for new future forward contraceptive technologies. Next slide. In all, we identified technologies responding to 8 different design considerations. We'll be presenting just 2 of those. The first one we've labeled Power to the User. Next slide. In both countries, participants described ways that social norms were shifting. In Kenya, many of the women we met appeared to bear the burden of managing their families alone. In India, it was all about the extended family, so many of the women we met were living with extended family members, but even then, younger women and their partners indicated that they wished for, and they talked about ways they sought to have more autonomy in planning and managing their families. One of the insights that we came up with as we were doing our research was the importance of discretion. So discretion in matters of contraception were important in both settings, but for very different reasons. In Kenya, because contraception seemed to be regarded as a private matter, and sometimes something that was limited to the woman herself, they talked about preferring methods such as the injectable that could be used without partners or families finding out. Conversely, in India, because contraception is not a private matter, women desired methods that enabled them to keep some kind of control over their choice and use. So it was often within their relationship with their partner that they would try to make some of these decisions. According to a chemist in Delhi, it's usually men who come to buy pills for their wives. They won't even know the names, but they'll carry the previous packet with them to show which one they want. Next slide. Another insight had to do with providers. Providers' perceptions and biases can impact the access and method choice for women across different reproductive stages. In India, stigma around premarital sex as a barrier, acted as a barrier for unmarried women to access contraception. This was especially true in public health clinics. Conversely, in Kenya, the group that met with adolescents talked about adolescents calling out their counseling, calling out the act of being over-counseled or being asked too many questions about their sexual relationships. And for that reason, they often preferred visiting chemists over youth clinics, even though the latter provided free of charge products and services. Even community health workers who stocked oral contraceptives are only allowed to give it to clients once they have obtained a prescription from a local clinic. For that reason, girls would resort to using emergency contraception when they had sex, which was sometimes bought by boyfriends from a private clinic. It was surprising. I was in the older women's team, and even there were barriers to contraceptive access for older married women. In Kenya, older women felt embarrassed or self-conscious to go to public clinics or chemists, as they didn't want people to know that they were still sexually active. So one nurse that we spoke with at a private clinic in Nakuru said, if an older client comes to the clinic, I'll make sure to seat her in a separate section so that she won't be embarrassed sitting in a room full of young girls. Next slide. I think it's this slide. So, even though multiple products are available, women face a lack of options when it comes to finding a contraceptive method which combines their preferred delivery mechanism and duration. For example, although longer-acting methods like implants and injectables provide more reliable protection from pregnancy, women worried about their ability to opt out of a method if they experience side effects, as well as how long it might take after stopping the method to get pregnant again. A method like oral pills that could be stopped easily in case of side effects were often deemed unreliable and prone to accidents. In Kenya, we met women who would cycle through 3, 4, and even more methods over their reproductive lives as they rebounded from an unplanned pregnancy while using pills or the calendar method, discontinued injectables due to side effects, and eventually adopted more invasive methods such as IUDs. In India, many of the women we met didn't use a contraceptive method at all until they chose to get sterilized after having perhaps even one too many children. They chose sterilization over other methods and tolerated the pain and discomfort of the procedure so that they could be tension-free. It was seen as providing reliable and permanent contraception and didn't require experimenting with long-acting, reversible, but kind of medical methods, or methods that were associated with a lot of different side effects. In that way, trade-offs were worthwhile to limit fertility reliably and without this sort of medication. Next slide. Earlier, I believe Babita mentioned the use or the development of user profiles that emerged from our research. One of the profiles that aligns with our power to the user principle is entitled the Empowered Hustler. In this profile, and it was not unique to Kenya, but perhaps a bit more aligned with our Kenya research, the Empowered Hustler is younger, empowered to make her own decisions. For her, the idea of sort of settling down means no more fun or it's too much responsibility. Given her age and unmarried status, however, she may confront difficulties obtaining contraception, especially from the public sector. So she may choose to go to a youth-friendly clinic or purchase something through a chemist. Next slide. Many women, and not only those fitting our Empowered Hustler profile, wanted to be able to use contraceptives on their own terms, when they want to use them, and with limited reliance on health providers. Next slide. So thinking about the research insights and the potential user profiles, we identified 3 actionable questions. They're similar to the challenge cards that Neha showed you all a little bit earlier. These were used to ideate around new contraceptive concepts. So that we asked, can contraception come in formats that reduce dependency on the usual sort of provider systems? Can contraception fit more discreetly into the everyday lifestyles of women who use it? And can contraception become more relatable to specific stages of women's lives? Next slide. So what kind of contraceptive concepts emerged from our workshop that might enable women to use these methods on their own terms? Well, they range from products that could be hidden in plain sight, for instance, like this contraceptive jewelry, or contraceptive in India, contraceptive bindi, which is the little tika mark that they might use on their forehead, to more technology-driven solutions like an IUD that could be self-inserted by inserting a gel-like solution that hardened and then easily removed by inserting another solution that dissolved the device. So these are just a few of the kinds of ideas that came up around this power to the user idea. And I'm going to hand it over now to Anna Lawton, who will talk you through another case study. Next slide, please.
Hello, my name is Anna Lawton. I'm a socio-behavioral researcher at FHI 360. The second case study we'd like to present speaks to the development of the design consideration we've titled Fertility Friendly. As Betsy's just done, the next few slides illustrate some of the research insights that laddered up to this important need. I'll also discuss one of the user profiles we developed and for which this design consideration is especially relevant. And finally, I'll share a couple of concepts that emerged from the workshop in response to the need for new methods that are fertility friendly. Next slide, please. One of the meta-insights that emerged from our fieldwork revealed that despite the sense of growing empowerment among especially the younger generations when it comes to things such as relationships and sexuality, normative change takes a long time. For most, the pressure to marry and conceive young remains the standard. Women are expected to assure family lineage, and demonstrating the ability to conceive remains a key responsibility associated with the role of a wife or a partner. When it comes to fertility and how it is understood, little has changed. It remains sacred and perceived as something that needs protection. The need to demonstrate one's fertility immediately after marriage was called out as important by women in both India and Kenya. In India, marriage and motherhood are the reality for most women, irrespective of their level of education and employment, as the family has to be their first priority. Despite some young empowered girls going against the grain to delay marriage, or indeed some who said they would avoid the institution altogether, the pressure to settle down persists even for them. We had several focus groups with young women in India who represented more of the progressive fringe, and they all noted the familial and societal pressure to settle down young, whereas their aspirations were around further education and work. For many Indian women, entering or re-entering the workforce is only possible when children are of school age or grown. We found that women's negotiating power within the family increases as both they and their children grow older. In Kenya, the need to remain fertile continued even in the later years of a woman's life, in cases where she is remarried, she loses a child, or her husband desires more children. Kenyan men typically desire large families and equate their having many children as a sign of masculinity. In India, this perception is steadily shifting given the multiple government programs aimed at promoting smaller families. An example of this is Hum Do Hamari Do. It's a Hindi slogan that translates to we two, our two, meaning one family, ideally 2 children, and it's intended to encourage family planning. Next slide, please. Many of the cultural narratives and perceptions, and indeed misperceptions around modern contraceptive methods arise from the desire to protect future fertility and pregnancy aspirations. For women who have not yet had children, the fear of becoming infertile as the result of using contraception is an enormous barrier to use. In both India and Kenya, the women we spoke with consider irregular menstruation and the absence of periods, also known as amenorrhea, to be abnormal. And menstruation is for them a natural indicator of one's fertility, and indeed their overall health during their reproductive years. Because hormonal methods are closely associated with undesirable side effects, including menstrual cycle changes, for many women this suggests an impact on fertility, so it stands to reason that these are less popular among some women. Something we heard from a lot of women is that hormonal methods introduce chemicals into the body, and as these accumulate, they have adverse side effects, including an effect on fertility. When the length of time it takes to conceive after using hormonal contraception is unpredictable, this can cause anxieties, even within families that already have children and have therefore demonstrated fertility. Injectables, which are still the most common modern method used in Kenya, are associated with a particularly long return to fertility, some 6 to 9 months on average. Knowing this, some of the providers we spoke with said that they will actively dissuade some women, especially those who have yet to conceive or who hope to conceive in the near future, from using that particular method. As I noted earlier, a woman's childbearing ability is considered paramount in both countries, and there's a fear of partner and community rejection if you're not able to conceive, almost irrespective of how many children a woman may already have. And because hormonal methods are not perceived as providing a reliable and swift return to fertility, many women turn to natural birth control, such as withdrawal and the rhythm method. However, these are not always reliable, as they depend on partner compliance, as well as basic numeracy and body literacy in order to keep track of cycles, which is not universal. The absence of periods, a side effect associated with certain hormonal methods, including implants, hormonal IUDs, and injectables, can be more acceptable in later stages of life. If a woman has achieved her desired family size, it makes sense that she no longer needs that natural indicator of fertility, and this opens up a window of acceptability for hormonal methods. Interestingly, however, whereas women in India who have achieved their ideal family size tend to opt for sterilization, even at young ages, we found that women in Kenya ruled out the use of permanent methods in case their situation changed, as I noted earlier. This could be because of the death of a child, for example, or becoming widowed and remarried. And instead, they preferred reversible, long-acting methods like implants and, to a lesser extent, IUDs. Next slide, please. In addition to the user perceptions I just described, health provider bias can also limit access and perpetuate misconceptions around contraception, particularly hormonal methods. Providers tend to prescribe very specific methods based on generalizations around a client's life stage. For example, is she married, unmarried, has she conceived, and particularly in the case of India, what is the gender composition of her children? As Betsy noted earlier, the stigma around premarital sex acts as a barrier for unmarried women to be able to access contraception. For married women who have yet to conceive, the fear of infertility is a deterrent to contraceptive use. Providers themselves often worry that hormonal methods could affect a woman's fertility, thus leaving these women intent on delaying childbirth with very few contraceptive options. Interestingly, in India, where women tend to marry young, the pressure to have children immediately after marriage is beginning to ease a little bit, with husbands and mothers-in-law favoring delaying childbirth until the woman seems ready for motherhood, both physically and emotionally. That being said, however, they do not condone the use of hormonal contraception because of fear that it will negatively impact her ability to conceive. Next slide, please. The conservative romantic was a user profile and an archetype particularly relevant in India, though conservative romantics exist in Kenya too. In this user profile or archetype's case, she is a young wife. She's in a stable and caring relationship with her husband, from whom she seeks support, guidance, and financial security. She has traditional values and finds fulfillment in providing for her family. Her sense of agency is impacted by her lack of schooling, and she tends to defer on matters such as health and family planning to her husband or providers or family. They've not yet reached their ideal family size, and she prefers methods that are natural or traditional because her husband is a strong aversion to modern medicines and also wants to allow for spontaneity versus those that require pre-planning, which echoes their sexual activity and routine. Next slide, please. So the design consideration that made itself abundantly clear during our research was the need for fertility-friendly contraception that put to rest any uncertainties around how long it would take to become fertile again after use, or indeed that ideally even augmented or boosted fertility in some way. Next slide, please. So the actionable questions that surfaced in terms of the unmet needs around contraception that have to do with fertility included: can contraception ensure a reliable return to fertility? Can contraception offer easy ways to track one's fertility? And finally, can contraception be designed to closely match women's own sexual routines? Next slide, please. So briefly, two of the concepts that came out of the ideation events that responded to the fertility-friendly design considerations included iBirth. This was a rechargeable fertility tracker, along with a contraception dispenser worn on the hand or the ankle. It's connected to a mobile phone, and it uses heat technology or fingerprint recognition to identify the user. It constantly modifies itself to make real-time adjustments to the drug delivery system. So this method speaks to customized contraception and only delivers contraception when needed, thus reducing the chemicals taken into the body, whilst also tracking her fertility, which can be used both for contraception as well as planning for conception if desired. And then the second method I wanted to mention was what we're called the bioautonomy method. This was a smart implant. It's customized to the woman's body so that there are no side effects, and it can include supplements for energy and health, which was something a number of women suggested as desirable in a contraceptive method. It biodegrades after 5 years, but it can also be removed earlier if desired. This method gives additional benefits and health-giving properties. It's customized, so she receives enough to effectively contracept without all the negative side effects. And finally, it negates the need for removal because it's biodegradable. However, if she does want to remove it before the 5 years up, that is also an option. And now I'm going to pass it back to Heather.
Thanks, Anna. So as you can see, we were able to gather quite rich data through our efforts, and our hope is that these insights will serve as a foundation for the broader contraceptive product development space, including the work that is ongoing by FHI 360 and other groups. We also hope that results from these efforts will generate momentum to move more promising concepts through early stage product and/or clinical development. So I'd like to take a moment to recognize the many dedicated partners who are responsible for the conduct of this research, including my colleagues at FHI 360, Betsy and Anna, and the many fabulous staff at Quicksand, including Babita, Neha, Selvin, Rikta, Ocean, Hugo, and Kevin. I'd also like to thank Pablo Van Heck, who is a freelance consultant who served as the project manager, and last but not least, the Bill and Melinda Gates Foundation for, one, funding this activity, and also for the active participation of Mary Aikenhead and Kirsten Vogelsong. Lastly, I'd like to thank the many women who participated in our research in both countries, as well as participants from our ideation workshops. It goes without saying that this work would not have been possible without their participation. So as you can see, this is our Kenya field research team. And this is the group of participants from our Kenya Ideation workshop. Here is our India field research team. And here are our attendees from the India workshop. I'd also like to take a moment to thank all of you for once again taking time out of your schedules to join us as we went through this project that is very special and important to all of us. And we can now open the floor to questions. Okay, we have one.
Yeah.
Oh, go ahead.
No, this is Betsy. I was going to say, should we maybe answer the question that was posed on the
yes,
in the question box?
So we have one in queue, and this is from one of our participants in the ideation event in Kenya, actually, Emily Krogstad, and she's asking what type of participant consent and ethical approval was required to conduct this type of research in Kenya versus India. And Betsy, would you mind taking that one?
No, I'd be happy to. So, you know, in both places, we obtained, first of all, IRB review at FHI 360, and then locally in each of the different venues. So in Kenya and in India, we did with consent request written consent. In both places, written consent was required, and we requested specifically consent for audio recording, for any kind of photographs or visual material as well. One of the differences between Kenya and India, however, was concern in India about the use of these materials, and especially any of the videos and the photography, the use of those more widely, for instance, being put on social media or being shared in materials outside of the specific workshop venue. So that meant that in India, any of the visuals that we even have been sharing, I think on webinar, or that will be in reports, are not of the specific participants in our research studies. So we let them know that that information, that those visuals would not be shared outside of our small workshop environment. So I don't know if my colleagues, is there anything else that I've missed on that? Did require some real workaround for the India side.
Mm-hmm.
Yeah.
Okay. The second question is, what do you feel is the cost barrier for products to enter these markets? So I could go ahead and take a stab at first during this. I'm going to initially address this from the perspective of developing new methods and what the cost barrier might be. And for the development phases that we're going through, if you're utilizing a platform that is novel, of course the cost is going to be higher. And one of the things that we strive for, as we mentioned, is to make the methods that we are developing cost effective. And one of the terms that we work with our partners very closely on is ensuring global access. We have clauses in our agreements to help drive this from the get-go. But I think that the biggest barrier as far as procurement is that a lot of these methods are coming through donor agencies, such as USAID and other private donors. And so they have limited resources. So the cost barriers really are comparative cost to what's already in the method mix. So what we're aiming for is we really can't be providing methods that are more expensive than what's currently available, because that's what's limiting some methods that aren't currently available in the broad method mix, such as implants, and particularly the LNGI-US has had some challenges with this because the cost is so high. I don't know if anyone else wants to jump in on that question as well.
This is Betsy. I was just going to add, and it's not something that we addressed directly during this overall project. Even in the ideation workshops, the idea was for this sort of multidisciplinary group of ideators to suspend concerns around potential cost of developing new methods, and really just to put out like what kinds of methods would be most responsive to user needs. I think the idea behind it is that sometimes the initial investments may be large to come up with something really new, but over time, if it's responsive to those user needs, that there may be ways to drive down those costs. So I think that that's a kind of a question that remains out there in the sort of next wave of beyond this project. How do we move forward? How do we identify, sort of call down, decide on which products, which concepts to try to move forward to future development? So I guess that part we'll have to see. It'll be up to funders to some extent in helping determine that.
Thanks, Betsy. And the next question, if you guys don't mind taking that at Quicksand, Babita, is how early and how often do you need to do these ideation workshops as R&D progresses? Also, could you comment on the timing and intersection of ideation and HCD in product development?
Yes, Heather. So I think what's crucial about workshops like the ones that we did in both Kenya and India was that there were two vital things about it. One is that it really brought the end user, the woman's voice, right into the center of all our discussions. Often, several of us who might be involved in product development tend to get caught up in the everyday of it. So in the sense that a workshop of this kind brings the woman back to the center, it is really crucial, and thus it is an effort that we need to keep alive through the R&D process. And the other crucial aspect about a workshop such as the one that we organized was the fact that different disciplines really got together and were put in a format where they could work openly and quite closely with each other. Again, in our everyday lives, maybe we tend to get caught up within a certain discipline or a certain perspective, and the opportunity to be able to break free of those and be inspired and challenged by other disciplines is quite crucial to the success of workshops such as these, and therefore we feel it's quite an important input into R&D development processes. In terms of the other part to the question is about the timing and intersection of ideation in HCD in product development. This could be a long answer depending on what stage of the product development we're really in. But in the case of this project, we were specifically looking at far future product development, which is why we felt that HCD as a process and the sort of ideation workshops that we organized that helped people get out of the usual constraints that they might put on themselves was really, really important to be able to think of what are these moonshot ideas that can drastically alter women's experiences around contraception.
Thanks, Babita. The next question is, I'm going to punt this over to Betsy and Anna. Did you find a correlation between the desire of duration and stage of life of the women?
Well, because the research was qualitative rather than quantitative, I won't use the word correlation, but certainly women who had achieved their family sizes or women who were a bit older were looking for permanent methods by and large. And even in India, some of the younger women, I mean, they were younger, but they'd still, I was actually quite surprised to note, at least in our samples, that younger women also still had quite a few children. So some of them were looking for permanent methods. And, you know, on the other hand, even in Kenya, in the sort of older group of our group that was looking at older women, some of them still, as Anna noted, were kind of wanting to hold out the possibility of having future children, particularly if something about their relationship changed. So I mean, there have been plenty of quantitative survey types of research out there that do show some correlations around that, and I think that was held up to some degree, but with some interesting differences, some interesting, some interesting contradictions, I'd say, to that.
This is Anna, and I'll just add that in terms of duration, I think we could safely comment on the fact that long-acting reversible contraception was not something generally taken up by adolescents or those who are unmarried young women. That tended to be shorter-term injectables, condoms, etc. The longer-acting, such as implants and such, and IUDs to a lesser extent in both contexts, were taken up generally by those who had already had children and were looking to space, and indeed, as Betsy noted, sometimes even older women who just wanted to have that option to conceive again. So duration and life stage did have a sense of a connection for sure.
Yeah, and maybe just one last thing to add to that is I was a bit surprised at how much the idea of on-demand kinds of methods, how important that was, or how desirable that was in both of our country contexts and kind of across the different life stages. But the idea of something that was on demand but also highly effective was important. Maybe that's one of the contraceptive gaps out there. Heather, we'll punt it back to you if there are other questions.
Oh, yeah, sorry. So I'm going to go ahead and ask you to follow up with this question as well. Someone is asking that you follow up a bit on any significant differences between rural and urban areas in terms of preferred methods within both countries.
I think that's a little difficult. I might ask the Quicksand folks as well, because in each country and in those different kind of places these venues that we went to, we did get a little bit out into the rural areas, but I don't know how much we saw as real differences in the rural versus urban areas.
Or kept those as teased out differences, because I think in some part we were trying to find common ground amongst rural, urban, and peri-urban areas in order to create sort of more high-level insights that spoke to a little bit more of a diversity amongst the spread of users that we contacted. So rather than parse out those differences, we sort of rather tried to consolidate them.
Right. I mean, some of the differences had more to do with how women access contraceptive methods in those various places. So community health workers were very important in both countries when you got out to more rural areas. And the mix of methods that might be most available were slightly reduced, but there were still thinking about, you know, in India where women, well, I guess Kenya as well, where women still made the trek to a more urban area if they wanted something that was, for instance, more permanent or long-acting and required, you know, a higher level of intervention from a provider. So when it came down to what they desired, can't think of anything that really distinguished by geography like that.
Okay, thank you for that. The next question is, there's two that are quite similar, so I think this response will address them both, and that is, are the findings being taken back to the user groups in India and Kenya, or has that already happened? And if so, what has their feedback been?
So we did do a brief user concept testing at the end of each ideation event with some of the concepts coming out of the events themselves with users. In both cases, in the case of Kenya, some that we had spoken to during the research, as well as some additional users, and then we did the same in India with people that we had indeed spoken with during the research. But that is the extent to which we have sort of temperature tested or pressure tested the concepts and insights coming out of the research to date. But that's certainly something, as we proceed with the prototyping and development process, to continue to go back to the field and test these ideas with users in true human-centered design style.
And just to add to Anna, I think what we were trying to test also wasn't so much the technology or the form, or what was behind the contraception, but the user experience is what we were looking to get a sense of. So that's what we got, at least quite rapidly at the end of these workshops. We got some initial feelers for what sort of experiences were desirable, what did actual, hiding in plain sight mean, what was on demand for users. So we've got some valuable feedback out of this already.
And maybe linking that back to an earlier question about HCD and when you might use it in the product development pipeline, I could imagine that depending on, whichever concepts might be moved forward into laboratories, into further product development, that there would be opportunities or perhaps should be opportunities to go back to similar kinds of end users and gather more information that's specific to that particular product being developed, and to gather more information and input into the design, the delivery of, et cetera, of that particular method.
Okay, thank you. And I see that we're coming up on the end of our hour, but there was one more comment that one of our colleagues posted that I want to go ahead and mention, and that is that the comment was that the LNG IUS is available for free as a donated commodity, but there are some challenges. So Sophia, I'm not sure if do we have time for more questions at this point? Can we keep going?
Yes, you can keep going. I imagine several people will have to drop off. I see a few people dropping off. You feel free to continue, and we can record this and circulate more, or we can also address other questions in writing later. Up to you, Heather.
Okay, perfect. Okay, so we'll go ahead and take a couple more questions. And I think it's also worth noting that we'll have written answers to all of the questions submitted that'll be available after the webinar as well. And I also, while I'm pausing, want to point out, I moved this slide back to display our project microsite, where you'll be able to find more detailed information about our work, and I'd urge you all to please take some time and peruse that site as well. A lot of effort has gone into that, and the Quicksand team have done a great job of developing that. So it's futureofct.org. Okay, so next question that I'll pop up here is, from the female perspective, how important was the partner's understanding and support related to CT choice?
I think it depended. I mean, that was one of the sort of meta insights in Kenya. We spoke with partners at times. Sometimes we spoke with couples. When we did speak with couples, and I'm thinking more directly about some of the experience that I had in my group, men expressed opinions, but it didn't seem as important for at least a small number of couples we spoke with. It seemed like it was really a woman's choice. In India, maybe more so. We didn't, the idea that a husband might have a lot more input in which method was being used, and particularly related to the kind of side effects that she might experience. I mean, those were important. So it really varied across, at least from my experience, it varied across the two countries, and even kind of individually by women or their relationship context.
For my experience, and I generally was focused on adolescence in both contexts, I did find that in India, the need for sort of partner agreement was very, very important. In Kenya, you found more instances of quote unquote clandestine use, so use that wasn't known to the partner, but that wasn't something that was ever even really considered in amongst the users that we spoke to in India. It was very much a choice made by the couple, in terms both in choice of method and choice to use contraception. But in Kenya, we did find more use that was perhaps just an individual choice that might have been withheld from the partner.
Okay, great. I think that is all we have at this point.
There was this question about the cost of contraception in those two countries. How much are women paying for contraception? And I could just say that clearly women are paying for contraceptive methods. Even young women are paying for contraceptive methods at times when they, especially if they're purchasing emergency contraception or buying something from a chemist. There is use of these public health clinics, and so sometimes the cost is subsidized and quite low. But the issues around cost came up in our research, particularly around the cost of managing side effects, or the in India, for instance, well, I guess also in Kenya, when women went to get either for sterilization or a method that might require them to be at home for a while, then they took into account the foregone work that they might have, or the cost of childcare, or the cost of travel, et cetera. So cost is an issue that women think about, women and men, and families sort of think about when they're determining which methods they're going to use. But it's not as much even the cost of the actual product as all of the other related costs around it.
Okay, great. Thanks, Betsy. And I think that is the last question for us. So again, thanks to everybody for joining us. And I don't know, Sophia, if there's any final business we need to announce or attend to.
No, I think that's it. This webinar has been recorded, and we'll circulate this recording to, I think, everybody that registered, and even maybe beyond that. Other end, as you mentioned, we'll have sounds like you'll put together a questions report for everybody. And otherwise, I would just like to thank everybody for joining and thank all of our presenters. This was really excellent and I think very relevant to a lot of the priorities of the RHSC NERC Caucus, and we're really grateful for your time.
Thanks. Thank you.
Thank you.
Bye.
Thanks, everybody. Okay, bye-bye.